lectures. My name is Negedu Godwin, and I'm your regular anchor. I want to acknowledge these wonderful people who have contributed immensely to my knowledge, for which I'm most grateful. This lecture is a continuation from the lectures we had before. You need to check the link in the description. We started a lecture on principles of pulse echo imaging and display modes. So in the last lecture, we discussed principles of pulse echo imaging. So today we're going to continue with display modes, and let's learn how displays are done. All right, principles of display mode. There are several methods of displaying ultrasonic echo information or ultrasound images. You could do that with the A mode, the B mode, or M mode. So the A mode actually means the amplitude mode, and it was the first form of echo display used in ultrasound instruments. Now, in this format, echoes are presented as a vertical spike along the horizontal base. Yeah, and this image will give you an idea of what's used to be. You have an image for the biometric of the eye, and a graph to help you see what's going on. Now, A mode has only one spatial dimension, that is distance from the transducer. Now, the image looks like a skyline of a major city, say Manhattan skyline. Now, the height of deflection, or the spike up on the vertical axis, represents the strength or amplitude of the returning echo. The location of the deflection or the spike along the baseline will represent its axial distance from the transducer face, and it relates to the reflector depths. Now, in the 60s and 70s, before the advent of CT scan, A mode was actually used for performing a procedure known as the echoencephalography, and it's still used in ophthalmic biometry to provide measurements of structures in the eye. The advantages of M mode is basically simple. It has good axial distance data. These are the advantages. But the advantages is just one-dimensional display. It has poor display of moving structures. Now, B mode, which is otherwise called brightness mode, represents the echo reflection. What B mode does is that every echo reflection, it represents it as a brightened dot. The reason for the name, echo bright mode. When an echo returns, the dot lights up with brightness that is proportional to the amplitude of the returning echoes. The brightness and the size of the dot corresponds to the echo amplitude. The stronger the echo amplitude, the larger and the brighter the dot on the image display. Now, returning echoes appear as dots on the line of travel. Yeah. Now, the distance of the dot from the transducer is determined by the ultrasound pulse travel time, which we call the go-return time. And this image will show you the scan lines and echo, amplitude, strength vis-a-vis brightness. The gray shade of the dot relates to the strength of the returning echo, and there are 64 shades of grays in the grayscale. In the grayscale of black and white, you have 64 shades of gray. But present-day real-time scanners, you have all of them are basically beam mode scanners because they produce two-dimensional grayscale image. What are the advantages of beam mode scan? Actually, a simple device also. They have good axial distance data. You can actually have a formation of the M mode and B mode real-time scan side by side. Yeah, but the disadvantage is one-dimensional, and it poorly images the moving structures. M mode stands for M in the M mode stands for motion, and it's also called T mode or time motion mode. Yeah, but it's generally known as M mode. M mode is a primary method of obtaining ultrasound information about moving structures such as heart and heart valves. Now, M mode records both the position and the motion of an interface over a period of time. Now, M mode takes the B mode dot and moves it with time, yeah, producing a wiggly line on the paper. Now, these lines present the position and motion of the reflecting surface as they occur in time. It is the only mode that provides information on the position of the reflector with respect to time. Now, if the interface, for example, a valve in the heart is moving, then the dots corresponding to it will also move, representing that wiggly line we'll talk about. Now, if an interface is stationary, then no motion through time takes place and a straight line will result. M mode images do not look like the anatomy they are recording. The operator must learn to recognize the normal and the abnormal appearance of M mode tracings. Now, M mode is not commonly used as part of echocardiography. Echocardiography study for both adults and fetus is not common. So, what are the advantages of M mode? It has excellent temporal resolution. The disadvantage is basically is one-dimensional display. So all the one-dimensional display modes, like the A mode, B mode, M mode, you can determine the axial location of the echoes along the path of the beam, but not the lateral location because ultrasound beam only travel in a straight line. But to get both the axial and lateral information, we need a 2D display. So the three modes that we described earlier will generally produce the echo data in their one-dimensional format. Yeah. However, we said we need the images in a two-dimensional slice of anatomy to facilitate the diagnosis of patient. So the two factors that makes it difficult to create a two-dimensional image are the ultrasound only travel in straight line, that's number one, and the beam is narrow. So the beam required for high quality images, we have narrow beam width which are required for high quality images with good lateral resolution. So these are two factors that actually makes it very difficult to create a two-dimensional image. But to overcome these difficulties, a 2D image is constructed from multiple beam mode ultrasound pulses. B-scan, let's look at B-scan. Now 2D ultrasound display is actually known as B-scan. To produce a 2D image or a B-scan, the beam must be swept through the tissue to produce a series of beam mode scan lines. The first B was known as the static B-scan. But in a static B-scan, a handheld transducer attached to an articulating arm was moved over the patient to produce a single static image comprised of approximately 100 M mode scan lines. Now each scan line was produced by a single pulse of sound. So the 100 pulses, approximately like 100 pulses were used to produce one static B mode scan. In history, static beam modes were used like in the 70s. They could produce decent static longitudinal cross-sectional image of the body, but limited to one image at a time only. So each time a new image was required, the operator needed to manually move the transducer over the body to sweep the beam through the region of interest. The static beam mode advantage is 2D display. You could have a longitudinal and cross-sectional view. It also has a large field of view, but the disadvantage is it's unable to display motion and is very operator dependent. Remember, every time you need a new frame, single frame, you need the operator to sweep through the area of interest over and over again. So this B-scan line of scan. So in the 2D real-time imaging, in the 80s, these 2D real-time images replaced the static B-scan. Now in real-time scan or system, the beam is automatically swept through the region of interest. Real-time imaging is the production of motion pictures of anatomy. Now this type of imaging consists of a series of frames that displays in a rapid sequence, which gives the impression of a constant motion or a constant motion picture to the eyes. What really motivated real-time scanning? To overcome the shortcomings of the B scanning, image both static and moving structures such as fetal movement, heart motion, vessel pulsation. It needs to be recorded. Yeah. And also there is need to perform a Doppler ultrasound. So the real-time pictures are automatically produced by the ultrasound system electronics by acquiring a large number of scan lines and combining the scan lines into a 2D picture. But initially this was done by mechanical real-time transducer, which were superseded by electronic array transducers in the 90s. Those electronic array transducers have significant advantages over mechanical transducers and standard equipment on all modern ultrasound systems today. But we arrived at the 3D imaging. So in imaging the 2D, in 2D imaging, the field of view is limited to a sector or rectangle shape of a dimensional image. Yeah, but 3D imaging allows the expansion of the field of view. It adds a third dimension to it. So in addition to the axial x-axis and the lateral y-axis. These are locations of the echoes. You can also display the elevation, which is the z-axis location of the echoes. Thus, these surface features can be viewed better. For example, like the fetal body or fetal face, you can view it better now that you have the z-axis applied to it. In this 3D, additional information can be obtained via planes after the image construction. Example like the coronary view of the biconate uterus. 3D is created by obtaining a series of 2D slices of conventional ultrasound information. The location of the slices from the 2D scan are identified and manipulated by the computer processor to construct a volume of information or 3D information of tissue and displays. Now, compare with the slice in a loaf of bread. Let's see the analogy. Each individual slice represents a single 2D slice. The combination of a series of slices produces a 3D volume of that loaf of bread. Yeah? So it is possible because the image informations are stored digitally, then manipulated for display at your workstation. So acquisition of a 3D image requires a large storage capacity of the system, large computer memory, faster computer processors, and so on. So 3D imaging is now popular, yeah, and they are used in many areas of diagnostic ultrasound as we make progress in technology. However, 3D is still viewed by the American Institute of Ultrasound in Medicine as an adjunct technology, not as a replacement for the 2D. So the 2D display remains the primary method of imaging regardless of the method of image acquisition. But there is a fourth one, the 4D. 4D is more like the live 3D imaging. So 4D ultrasound is not really four-dimensional like the name suggests, because there's no fourth dimension to it. It is the display of the 3D ultrasound in real time. And you may want to call it the live 3D ultrasound. But until recently, it took significant computing time to reconstruct live 3D imaging for a data set. As computing power continues to increase and accelerate, 3D processing time is rapidly becoming reduced to the point where reconstructed 3D data can be displayed in real time. Yeah, and that is popular now. And this whole description is what the 4D ultrasound is. 4D ultrasound is otherwise called the live 3D. The analogous to the 2D frame rate, the rate at which 3D images can be displayed in real time is called volume rate, at which is measured in volume per second. So we are looking for 4D ultrasound with an increasing fast volume rate in the future. But remember, 2D still remains a diagnostic consideration for all diagnostic purposes. While we continue to improve the 3D, 4D still remains a work in progress. Let's look at tissue harmonic imaging. You know that normal ultrasound beam consists of range of frequencies, like we said in the last few lectures. From this range of frequency, the lowest frequency component is called the fundamental, or what you call the first harmonics. Conventional ultrasound imaging requires the transmission of an ultrasound beam at the fundamental and also receives the reflected echo at the same fundamental frequency. Tissue harmonic imaging uses echoes received at twice the transmitted frequency, known as the second harmonics frequency, to produce images. Now, the ultrasound system transmits at one frequency but receives at double the frequency. So that's what you get in second harmonics. So what is the goal? The goal is to improve axial resolution, to improve lateral resolution, to reduce image artifacts, reduce noise, especially in obese patients and others who are difficult to image with normal grayscale imaging. Goal also is to increase contrast resolution. The tissue harmonic imaging improves lesion detection and tissue characterization. So using the same transducer, the sonologist can simply push the button for tissue harmonic imaging and improves image quality with the second higher harmonic frequency. Contrast imaging basically will require contrast agents. You use that to improve visualization of small blood vessels and vessels that are deeper in the body, improve tissue characterization for a better differential diagnosis, improve signal to noise ratio on Doppler examination. And what are the, let's see, these are some of the contrast agents that you use in ultrasound imaging. You have Abunex, used mainly for ventricular opacity of the heart. Levovis is used to enhance Doppler or color Doppler imaging, and also in B scan imaging enhancement. Echovis is used to enhance the uterine cavity and the fallopian tube, including tubal patency. So how does it work? Contrast image, or rather contrast agent, when they are introduced IV into the body, change the acoustic property of the tissue by introducing gas bubble into the system. The micro bubble movement produces an increase in scattering, which produces an increased echogenicity. The increased echogenicity produces an increased signal to noise ratio, which in turn creates a higher signal strength on the Doppler examination, which is seen as an intensification of the grayscale. In color Doppler, this allows more vessels to be visualized. Now, temporal resolution pertaining to time and time is actually pertaining to time and motion. Because it is the ability to accurately determine the position of an anatomy structure at a particular instant in time. Now, this is especially relevant in the imaging of rapidly moving structures. Temporal resolution depends upon two factors. Depends on the extent to which the structure moves and the number of images that are created in each second, that is the frame rate. For temporal resolution, time is the resource that must be managed. Sound travel at 1,540 meters per second. But when you convert that, you can get the unit as appropriate. Now, this means that pulses can travel to and fro a depth of 77,000 centimeters each second. Imaging with a single pulse to a specific depth in order to create a single scan line will require time. Imaging with multiple pulses to various depths to create a single composite scan line requires even more time. Presenting many frames in a single sequence, as occurs in the real-time B mode scanning, will require even much more time. So, image depths, number of pulses per line, lines per frame, and frame rate dwells for time. So, what are the importance of each of these factors? The imaging depths is significantly clinically significant. When you have a clinical significant organ that must be imaged, regardless of its depth, whether it lies superficially or deep in the body, the sonologist must adjust the system maximum depth. So the deeper the system image depth, the longer the receiving or listening time for each pulse. Imaging depth is controlled by the sonologist. Deeper imaging will result in longer listening time, longer PRP, and lower PRF. More time is required for each imaging scan line. Multifocal zones. An ultrasound pulse has only a single focal zone. So focal zone is the region where the beam that provides the finest lateral resolution. This is where the beam provides the finest lateral resolution. So by using a multiple sound beam with different focal depths to create a single image line, the lateral resolution is optimal at all the depths. Now this results in superior image quality. So the more foci per image line, the more pulses per image line. So multiple focal zones are controlled by the sonologist and are used with phase array transducer like your curve linear annular. Line density. Line density is the number of acoustic lines or scan lines that create a single image. Scan lines or lines of acoustic information add details to the image. Therefore, the more scan lines in an image, the better the image detail. So each frame of an ultrasound image is made up of individual scan lines. A single scan line is created by a pulse from the transducer. Now think of each scan line as the spoke of a bicycle wheel. So each of them travels individually, and that is produced by a single pulse. Line density is set automatically by the ultrasound machine and is not controlled by the sonologist. This transducer beam is automatically steered to a slightly different direction and then fired again. Now this process is repeated numerous times. If there are 100 lines in an image, then there are 100 pulses. 100 pulses are required to make the picture. One pulse of ultrasound is needed for each scan line, like we said. So how do you increase the line density, and what does it result to? It results to greater detail within the image, less space between image lines, more sound pulses per image, more time needed to create a frame. The line density is increased by decreasing the maximum tissue depths to be imaged and decreasing the frame rate. When maximum tissue depth to be imaged is decreased, PRP decreases due to decrease in go return time, and PRF increases. When PRF increases, more acoustic scan lines are generated. This improves the image details. When maximum depth to the image is increased, the PRF decreases as the PRP increases due to increased time of light, and the number of acoustic lines generated will be decreased, which decreases the image detail. Frame rate is the number of frames or images or complete scan that is created per second, with a certain number of scan lines making up the image on each frame rate. Now, a frame can be equated to a single page in a book. Now, the number of pages per second will be the frame rate. So you remember in those days, you make a cartoon in a book, then you want to create a moving image of that particular cartoon. You allow the book to flap sequentially on its own. Then you see the drawing move in the book. So the number of pages per second will be the frame rate, and frame rate is measured in hertz or frames per second. Frame rate is determined by the ultrasound system and is not directly controlled by the sonologist. So when a rapidly moving structure is imaged at an unsuitably low frame rate, some motion information will be missed. The image will appear flickery to flicker or jerk, like you used to have in the olden days motion pictures. So more frame rates per second will result to greater accuracy in locating moving structures, less time allocation to make each frame, and decrease line density. So the frame rate for a scanner must be greater than 15 frames per second in order for the eye to perceive the image as a continuous motion picture. Now, most real-time scanners have a frame rate of more than 30 frames per second. So let's look at equations for line density, frame rate, and PRF. A real-time scanner with a sector field of view expresses line density in lines per degree. A real-time scanner with a rectangular field of view expresses line density as lines per frame or lines per centimeter. So when the frame rate and PRF are constant, then the smaller the sector angle, the greater the line density will be. So this is the equation for frame rate. PRF is equal to line per frame times frames per second. And LD, that is line density, is equal to lines per frame over display width. LD, which is line density, is also equal to, now LD equals to LPF, that is lines per frame over display width, is for a rectangular field of view. Well, for a sector field of view, line density will be lines per frame on sector angle in degrees. So each frame of an ultrasound image is made up of individual scan lines. On the display, a single scan line in a beam mode is created by a pulse from the transducer, which we've said. The transducer beam is automatically steered to a slightly different direction and fired again. So it fires in this direction, then most of the direction fire in that direction, all in order to get the adequate scan line to form a frame. If there are 100 lines in an image, then we've said that 100 pulses are required to make the picture. So one pulse of ultrasound is needed for each line. And that is how the frame is formed. And remember that when a complete frame is formed, to create the continuous motion picture, we need more than 15 to 30 frames per second to give you that the B-scan motion picture without flickering. So I want to thank you for joining this lecture. Please like, share, subscribe rather, and put on the notification to receive all our free lectures. For more information about our paid classes, please send an email to sonaeyesdiagnostics@gmail.com or WhatsApp me at +234 9019 144 175 or visit our online store at sonoeyes.business.site. Please, I want you to attend to the quiz in the description and leave me a comment. Until the next lecture when I come your way again, keep learning ultrasound.